here are my disclosures. Let's start by saying that cable aortic access, I was asked to present my most difficult one. Overall, they're not very difficult. It works very well. But certain anatomies, you know you might get into some trouble with. So here's a transcaval case that we did knowing that we shouldn't. Patient was referred. It was a case I did. Actually, Dr. Letterman came to visit, and we actually both looked at the CT and said, this is not a good transcaval. The only window is in this sort of pocket of calcium, a little posterior, clearly not big enough to put any sheath in. So here's the aortogram. It's important to look at, we often do this a lot where we do a rotational cine. You can see by that red arrow that there's just this little focal ectasia that's extremely calcified. And we said, you know what, even though they were referred for transcaval, this is not a good idea. So we tried our hardest actually to go transfemoral. This was admittedly before shockwave. Things might be a little bit different now, but we ballooned it with a 6 and we couldn't even get sheaths anywhere close to through the calcium. So we took an 8 millimeter non-compliant balloon, still couldn't get even a 16 French sheath in. We were able to get an Edwards dilator. We busted open an Edwards dilator, got that sheath out with a longer transition, and then tried to deliver a core valve. And as you can see here, this is sort of your worst nightmare. You just can't push it through the calcium. Kept going with balloons. We were able to tried to get like a 22 French sheath in, figuring if we could get the sheath in, you know, a dilator that big, then we could get the outer diameter of the sheath in, and we couldn't. So we said, all right, well, our only option is to go through that small window. So we aimed a little posterior. And it's not the burn that's the problem in these cases. You're going to get through, right? You have to find, it's like, you know, trying to thread a needle, and you can do that. And so here we easily snare. And so our wire's through. But here's something very interesting. So we put the wire through, we put the microcatheters through, we put a Lunderquist wire in, and here I am trying to pull the microcatheter out so that we can drive over, and you can see just the whole aorta moving. And the reason is we sort of created a calcium lock, right? It's like handcuffs. In other words, the stiff wire bent things to the point at which the microcatheter is being locked by the calcium, since this is such a small window on the top part of some ectasia. So we were able to get the wire back out, and then we put a softer wire in, so we were able to get the microcatheter in, and then we couldn't drive any sheaths. I mean, here's a dilator trying to go over a soft wire, and you could see how you just don't have the stiffness to get the wire in. We couldn't even get a balloon over the soft wire. It was really hard to get a balloon in. Eventually, we were able to put a 3 millimeter non-compliant peripheral balloon to make a little hole. Still could not get the dilator of a sheath across. And eventually took a Cook sheath with a shorter dilator, and just with brute force actually probably just broke the calcium and eventually got the sheath in. So went on to deploy successfully a 34 Evolute, and now it comes time to close. So now when you're in this really focal pouch, which again you really shouldn't be in, you just don't know if you can actually get the disc close enough to the wall. So we pulled as hard as we could to try and tuck the disc of the occluder up against the wall. Here we are releasing it, pulling pretty hard to try and pull it back in there. And then the patient started to get hypotensive. We took this picture, and this is you often get with transcaval. You see a lot of shifting bowel and stuff, and it's hard to know, are they bleeding? Is that flow just shifting bowel, or is that actual bleeding? But the telltale sign that they're bleeding is that they're hypotensive, right? Because they won't be hypotensive if it's just a shunt. So there's a Reliant balloon going up, and you can see that focal sort of sausage pouch, because this is really not a good place to be doing the procedure from. So we took some pictures, and there's patients still hypotensive, and we could see some disruption of the calcium on the top edge, which is not unpredicted. And so we went ahead and put in a covered stent, because that's ultimately the solution for any suspected bleeding. That is a 45 millimeter long trivascular ovation IX. It's 22 in diameter, and then post-dilate that and you can see how you're asking a lot of a small endograft to be able to pouch out that far in. And so you can still see a little staining there, but blood pressure was restored at this point, and that little venous pouch was felt to be stable, and we left it alone. So that is the most difficult transcable that I've done in the past 2 years. If you CT this patient, this is what you'll often see. This is the CT equivalent of that venous pouch, which is a little bit of extravasation outside the plug, but decompression into the IVC. That's why these patients are stable. Fortunately, we have data that all of these go away. As long as the patient's hemodynamically stable, they all heal. There are absolutely no late complications from the plug from any of these slow to close holes. And we also know that by the end of 1 year, when you CT these people, all of these tracks are closed. So here, for a couple of extra slides, so here's my algorithm for covered stents. The Gore makes a Viabon, a balloon expandable, where the 11 millimeter one can go up to 16, believe it or not. So for anything under about 14, I think that's a reasonable small endograft that you can get in. For the neck size from that 14 to 18, I think the Endologics works well, and it's 14 French outer diameter. And then there's Trivascular Ovations. You can go all the way up. There's a 28. So you can really cover any aorta up to 26 millimeters with those three products. A couple of quick tips and tricks. Don't take any venograms anymore. It's unnecessary. There's nothing that you ever need to know from the venous side that matters. We scrape off the back of the wire, and we scrape off the Bovie pencil if there's any coating on it to get better connection. So just keep that in mind. Some of these Bovie pencils come with this clear insulating edge on it that you can take off for better connection. Don't let the wire buckle when you're crossing. This is dangerous because a pinhole leak is okay, but a slit in the aorta is not. So if you're not crossing easily, you just stop. And if you've tried multiple times and there's hypotension, it's conceivable that you didn't think you got into the aorta, but you did, and there can be these small pinholes. So you just have to be careful and cognizant if you've tried multiple times and failed. Another thing that people have called me with is unexplained hypotension in the middle of the case, difficulty delivering their TAVR sheath, and that's because there's not a lot of purchase on the sheath, and they push, and remember the sheath is sewn in at the leg, so what happens is it bows the whole sheath outside the aorta, and now it can't get back in. And remember, in this situation, you don't have any venous tract. You're out of the aorta, and you don't have any venous sink, so these people get hypotensive. Some tips and tricks for closure: only use this device. There's no reason to ever use a VSD and have any plug on the venous side, because you don't want to promote premature closure of the venous tract. No matter what angle you put the camera at to cross, when you go to close, just move the camera to whatever it takes to make the disc the most perpendicular as possible so that you know you've pulled back all the way to the wall. And some tips for bailout. Some people started doing routine ballooning of the aorta to push the disc over. I don't think that's necessary. And what it can do is promote premature closure of the venous tract. So I tell people, if you're going to do adjunctive balloon occlusion, now you're sort of committed to try and achieve a type 0 closure, meaning close it completely. So that's the summary case of one that probably shouldn't have been done that we got away with, and some tips and tricks on how to stay out of trouble. Thank you.